great honor to introduce you with Professor Reinhard Strametz. I hope that I pronounced it correctly. He is our special guest from Germany, and Professor Strametz will present the response capacity of health professionals in Germany during COVID-19. He is anesthesiologist. I hope that I said correctly as well. He is specialized in quality management, clinical risk management, emergency medicine, and economist. He is professor for patient safety at Wiesbaden Business School, General Secretary of Germany Coalition for Patient Safety. He is also a vice chair of European Researchers Network on Second Victims, the ERNST group, and he is involved in international research activities to strengthen the psychological support of healthcare professionals during and after stressful work situations. So with that, let's welcome Professor Strametz.
Yeah, welcome everybody. Diana, thank you very much for the kind introduction, and welcome to everybody, as I saw on the chat, in Europe and also in Southern America. Welcome to Brazil. It's a great honor and pleasure for me to talk to you about the response capacity of health professionals in Germany during the COVID-19 pandemic. Before I start, let me just give you some possible conflicts of interest. As already mentioned, I'm a vice chair of the Ernst Network, General Secretary of the German Coalition for Patient Safety, which was, of course, heavily involved in maintaining capacity of healthcare workers with several actions. I'm also a member of the Commission Healthcare and the think tank Support in Exceptional Situations of the German Institute for Standardization, who played a minor part in the prevention and the response of this crisis. And I'm also a member of some national and international boards, like the section group Perspective Resilience of the German Interdisciplinary Association for Intensive Care and Emergency Medicine, I will mention later. I've received some funding from the German Ministry of Health for working on some expert views and opinions about the second victim phenomenon. And I had the honor to work in the Austrian Standards International Working Group, developing a risk management standard for crisis, emergency, and business recovery management. Let me give you a brief overlook of the German healthcare system. So the German healthcare system is based on a compulsory healthcare insurance system. So everybody is insured in healthcare insurance. Most of them are in the so-called statutory health insurance, which is a premium-based insurance based on your income. Another number that is important to keep in mind for the German healthcare system is that we have a huge amount of hospitals compared to other European countries. We have roughly 2,000 hospitals and roughly 500,000 hospital beds. The intensive care ratio per 100,000 inhabitants is 33.9, which we'll refer to later. There are a lot of people working in the healthcare sector, so at least 1 out of 6 people in Germany in the working age are working in the healthcare sector, but most of them, roughly 1.1 million, in the healthcare and nursing care, emergency medical services, and midwifery. So these are just a few facts about the German healthcare system, which is a self-governed system and probably one of the most complex healthcare systems in the world, as self-governance is not only based on federal regulations, but also on a regional and statewide regulation system, which contains 16 states in Germany. So in theory, if something like a crisis, an exceptional circumstance happens, normally you have a resilience cycle which is set up by preparation, prevention, protection, and recovery. And normally you would make some effort in order to prepare for any critical situations like pandemics, for example, like natural disasters. And after something bad happens, there would be an emergency response. This is typically a very intense response, but only of a very, very short time. You then would switch over to the crisis management, which is not so extensive, but lasts quite long compared to the emergency response. And parallel to this, you should run your continuity management in order to come back to the normal situation, which we, to be honest, have not reached during the COVID-19 pandemic for roughly 2 years now. So if you do this correctly, you avoid the cost and the effort you have to do without preparation. So without preparation, of course, in the beginning, you save some money and some time, but afterwards everything gets worse. So your emergency response will be more expensive, it will last longer, and also crisis and continuity management will take more time. It takes you more time to get to the normal capacity. And to put it up by means of capacity over time, your total capacity would decrease more without human resilience engineering than it would with human resilience engineering. So the total time with a shortage of capacity and the overall effect would be bigger without human resilience engineering. So this in theory. So let me just start with the German situation about the preparation for pandemics. Of course, we have a national pandemic plan, which is not set up during the COVID-19 pandemic. And there were experts saying in 2016 up to 2014 that sooner or later some pandemic with the coronavirus will also hit Germany, and we have to prepare for this. So it's not about that we were not prepared, but some of the politicians were not able to listen until the first cases occurred in Germany. Besides this, we have 16 local pandemic plans of the local states, because we have to say that healthcare is a state affair. So planning hospitals and planning capacities for the healthcare sector is not a federal task, but it's delegated to the 16 states of Germany, which all have their own interest in this aspect. And so building capacity of hospital care is mainly a political decision and not in first line a value-based decision or a decision based on the real need of the population, with all disadvantages that can arise from this. So what we already knew, of course, was that there are second victims. I think we don't have to elaborate on this, as we are all familiar with some common definitions by either Albert Wu or Susan Scott. And we also knew that pandemics have high psychological impact on healthcare workers. Because as this is the SARS-CoV-2 pandemic, we already knew about SARS-CoV-1. So actually, I was there in Singapore being a tourist at the moment when SARS-CoV-1 had its breakout in Hong Kong. So I'm kind of used to wearing a face mask in public, even if not in hospital. But besides this funny fact, 1 in 2 healthcare workers showed signs of acute psychological distress and burnout and PTSD following the SARS-CoV-1 pandemic. So we knew that pandemics will have high psychological impact on healthcare workers. So this was also supposed when the first experts thought about the aftermath of the things that happened in January 2020 in China, whereas the rest of the population still thought that this would be no big deal in the future. So this was already known and led to an immediate response. Besides this, we have to look at the ICU capacity, which was one crucial aspect of the capacity of healthcare during the COVID-19 pandemic. And you see that on first sight, we are very well off in Germany with 33.9 intensive care unit beds per 100,000 people, as I already mentioned, and compared to other states in the OECD sector, this is seems to be quite comfortable. So one could say that we have no problem with ICU capacity in Germany, do we? Well, we come to this later on again. Because if you look at the ratio of German nurses towards their patients, it's a different situation. As you might remember that we have 1,928 hospitals, the allocation of nurses is quite suboptimal. So in Germany, every nurse has to be caring for 13 patients, whereas, for example, in the Netherlands or the US, it's only 5 up to 6 patients one nurse has to care for. And also in intensive care unit, which has, of course, different ratios, It's sometimes 1 to 3, up to 1 to 4 patients that have been cared for. So compared to other countries which have a strict 1 to 1 or 1 to 2 ratio. So also compared to the number of cases that are treated in hospitals, Germany, as seen on the right side in orange, has 19 nurses per 1,000 in hospital cases, compared to the OECD average of 31.9 nurses. So although there are a lot of people working in the system, and although we have a lot of technical capacity, the actual capacity determined by the actual number of nurses caring for one patient or caring for 1,000 cases is not so good in Germany compared to other countries. So we have a big allocation problem. We also knew that there are a lot of stress factors, and that the healthcare system itself is not a nice place to work, to be honest. There are some surveys, for example, the survey by Matthias Raspe and colleagues, or the analysis of Peter Koch, who clearly indicate that especially among young nurses and doctors who are intended to work in the system for another, let's say, 30 up to 35 years, there are a lot of factors of extremely high stress levels. There's a considerable amount of people referring to be burned out. 1 in 5 doctors asked in the surveys already stated that he or she had to take drugs in order to be fit on the job. And we also knew that there is a strong correlation between the reduced perceived quality of care they can provide under those circumstances, the reduced job satisfaction, and the intention to leave the profession, which worsens the dramatic staff shortage we already have in the healthcare sector. So since 1950s, Germany is importing nurses and healthcare professionals from all over the world in order to keep the healthcare system stable and in order to have enough people working in the system, which of course are missing in their home countries. So it's, from the global perspective, this is not a sustainable solution. But even with these mechanisms, we still don't have enough people, especially when facing the demographic change, which will increase the demand of healthcare workers dramatically in the future. So we already know about the second victim phenomenon, but maybe this is a selection bias, as we all deal with this, or as we all have joined the session voluntarily. We asked some young doctors and young nurses in Germany, first of all, do you know the second victim phenomenon? And then we told them what the second victim phenomenon is, and then we asked them whether they were affected already by this. And in CeVIT-1, which was conducted in 2019 BC, which does not mean before Christ, but before Corona, only 1 in 10 doctors knew about the second victim phenomenon, but 6 out of 10 reported to be traumatized by themselves during the first 5 years of their medical education, so at a very early stage of their medical career. And in CeVIT-2, which was conducted during the Corona pandemic, 3 of 10 nurses reported to know about the second victim phenomenon. So we cannot quite differentiate whether this was also due to the Corona pandemic or whether nurses in general are more aware about such phenomena. But also 6 in 10 reported to have been traumatized, especially also during the early stage of their medical career. Which leads us to the fact that a second victim phenomenon, although we can say that these were convenient samples, it's largely unknown in Germany, although it's a common phenomenon. So I don't know how the numbers are in other countries. Maybe it would be interesting to find out, because this was a finding we did not expect on this extent. So we knew a lot of things before Corona hit us. How was the response? How was our protection mechanisms? So I think you probably heard this phrase 1,000 times in the last 2 years. COVID-19 is a magnifying lens for all the problems in the healthcare system that were there before. And of course, In the beginning, there were high infection rates among healthcare workers, especially due to the shortage of personal protective equipment, which was also a big deal in Germany as global supply chains broke down, and the capacity storage of personal protective equipment that we had during the Cold War, for example, was not available at this time anymore, because last time there were a huge storage of face masks was the swine influenza in 2009, and all these face masks had run out of their storage time. So the high infection rates in combination with the fear of triage had enormous additional impact on healthcare workers, but also led to a dramatic improvement in the healthcare sector, to be honest, because COVID-19 was the most intensive and most effective booster for digital transformation in the German healthcare sector, which is not a success story, to be honest. We are not famous for building up airports at our capital city, and we're not very famous for implementing electronic health records. But due to COVID-19, there were things that were possible because we did not have any other choice to think about that improved the situation dramatically. So, for example, before COVID-19, there was no central publicly available dashboard about the intensive care capacity in Germany. So if you have worked at the intensive care unit, you just had to phone every station, every ward in another hospital, whether there were beds available. And it took only 2 weeks to set up a dashboard and register from the German Interdisciplinary Association of Intensive Care Medicine that's now publicly available to see how capacities are. Also, standards for manufacturing face masks, for example, were made freely on open access, available from Senelec and the German Institute for Standardization as the national authority. And also seminars were held up to empower manufacturers to produce such face masks within weeks, which is not the normal speed of development in Germany for such improvements. Also, it took about 4 days to set up a recommendation for maintaining capacity in the healthcare system, especially referring to systematic support for second victims and traumatized healthcare workers, which are, I guess, familiar to most of the audience. It's the 3-tier model from Susan Scott, which is slightly adapted. But also, we took a lot of emphasis not only on the therapy of second victims, the treatment of second victims or traumatized healthcare workers, which of course could also be traumatized by other reasons, but also on reinforcing the resilience of clinicians, as experts were aware of this pandemic, that this would be a marathon rather than a sprint, and that this would take roughly about 1.5 up to 3 years until we have fully recovered from this, which is still I think, very, very realistic prognosis. So we focused on the 3 aspects of the sense of coherence developed by Aaron Antonovsky and Emmy Werner, which consists out of meaningfulness, comprehensibility, and manageability, and linked this especially to the challenges for the hospital management to make resilient leadership part of their crisis management. Also, the German Coalition of Patient Safety suggested to put on clinical risk managers into the crisis teams in order to react appropriate to this pandemic. So was ICU capacity a problem in Germany? Unfortunately, it was, and it still is, because as you see in the intensive care unit register, which was set up in March, so the rise of the beds is not by building up intensive care unit beds, but by joining the register, which was mandatory by mid of April. But as you see, the capacity, which seems to be quite comfortable at about 22,000 beds, dramatically dropped down on the 4th of August by roughly about 5,000 beds, which was not because of any catastrophic event, but because of the different reporting scheme, that only beds could be reported as vacant that were be able to run by staff. So we had a lot of beds that were physically available, but there was not enough staff to run these beds, which is, if you work in intensive care units in Germany, it's a common problem, and it was a common problem just also before the COVID-19 pandemic, that there are simply not enough people working to run the beds we have. So it's not about the hardware problem, it's all about the staff shortage. And you see the capacity slowly is going down. And you have to keep in mind that we don't have only COVID-19 patients who require intensive care unit treatment, but also some elective and semi-elective patients who need some major surgery and need some ICU capacity as well, which was postponed in a lot of cases. So continuity of care broke down in some parts in Germany due to the COVID-19 pandemic, to say. So what about the recovery? Is there any recovery? In Germany, we are facing wave after wave, and it's somehow frustrating to see that the mechanisms will repeat and history will repeat, because we are not able to break these waves properly. And also our vaccination rate, to be honest, is below those in other countries. So some of these developments, especially the second and third wave, could have been preventable if the measures of protection would have taken more seriously than they were, because to be honest, the first wave was managed quite well compared to other European states, because we had these huge capacities and this dramatic and very effective emergency response. But to be honest, there have been a lot of deficits in the crisis management, also arising from different regulations of the 16 states, which also had impact on the negative impact on the resilience of healthcare workers by comprehensibility or manageability aspects. I'm still an optimistic person, and I still think we have a huge capacity of resilience in our healthcare system, because in July this year, some of the hospitals were hit dramatically by a flood disaster due to heavy rain, which covered about 200 liters per square meter water within a couple of hours. So as you can see, in one hospital, in one of the areas that were hit hardest, this hospital was given up at 3 o'clock in the morning on the day of the flooding, and the hospital was completely destroyed in the first and second floor and the basement as well, as you can see. And also this catastrophe normally could close this hospital for months, but if not for years, or maybe could close this hospital forever. But thanks to the tremendous work of the intensive care unit staff, which you can see here, which helped to rebuild this hospital. So it's the healthcare workers, it was a huge amount of volunteers helping. It's nearly unbelievable, but this hospital reopened on the 4th of October, 2.5 months after this big catastrophe. So I still have hope that there is a lot of resilience, as this hospital is known to have an excellent management and a high percentage of self-identification of the people with their own so-called own hospital. So to sum this up, what are the lessons hopefully learned in Germany? We had a great short-term response. We have a lack of resilience, and the recovery is still to be considered as insufficient. We also saw that psychological support is mandatory, but we also saw that it has to be a low threshold psychological support. Sometimes there were psychologists going around the wards asking somebody if he or she needs help. And the answer was, no, I don't need help. I have patients to care for. So peer support really got interesting and important. And I think one of the lessons learned is that we need to establish peer support programs combined with other high-level treatments in order to reach the healthcare workers. The systemic capacity we have, or we should have, requires increased resilience of healthcare workers, and hardware alone does not save lives, but hardware alone is not the sufficient condition the first thing that was optimized was our hardware and the storage of personal protective equipment, which is now available everywhere in Germany, as well as the vaccination doses. So as a very high income country, we don't have a lack of this, but we still lack of qualified people working to gain the benefits of all this hardware. And neglecting mental and emotional status of healthcare workers avenges itself. There were a lot of healthcare institutions who paid a high price for not keeping an eye on the mental and emotional status of healthcare workers. There were even some hospitals where masses of healthcare workers just turned over and hired in another hospital. So it's a dramatic situation for some of the healthcare providers in Germany. My personal lesson learned is that staff shortage can be regarded as the climate change of healthcare system. So for me and some other risk managers, it's the most relevant risk for maintaining capacity of the healthcare systems at all. If you look at the average age of a general practitioner, rising nearly up to 60 years right now, year after year. And if you look at the people leaving the healthcare sector, so actually in Germany, there are more people leaving the healthcare sector than entering the healthcare sector, although we have a huge deficit in staff. So if we do not act decisively and aggressively towards this development, the slow development, there may be at some part a tipping point compared to the 2 degrees centigrade of global warming, which we cannot turn back anymore. So I think we have to really put emphasis on this in the healthcare sector within the last couple of years. So, but as I'm optimistic, and as you could see in the last example, my lesson learned is also that faith may shift mountains, but resilient healthcare workers will do as well if necessary, if you keep them resilient. So thank you very much for your time. And now I'm happy to take a time out and to join the discussion. Thank you very much.